Now, it doesn't say there was one particular thing neurologically. It's going to be a combination of metabolic and structural issues. It's not always just one single thing. You all know that from doing this job for so long. They give you two definitions. Prevalence, that's how many people have this in a given population, and incidence, the number of people diagnosed with a particular disorder in a particular time frame. Now, this says 1 year, but we're talking about a particular time frame. These definitions are important when you read studies and try to interpret what it is they're saying. Remember, I told you that on that gathering of eagles, there's 5 best and 5 worst for 2013. They do it every year. There's 2014 they had it. They have it for 2012, and you can go back and look at the 5 best and worst articles. Now, interestingly, in 13, I think it was, or maybe, no, it may have been 14, a lot of it had to do with airway and poorly done studies on resuscitation, cardiac arrest, and airway. So it's going to open your eyes, I think, a bit to understanding that this trend that we've had with airway is maybe we were being led down the primrose path, as the old saying goes. Only Jesse has to know this slide, so don't worry about it. I got it. We're talking about here some findings that we see in patients who have neurologic issues. Now, look at these different physical findings. How many of these findings can you link to all of these diagnoses? Yeah, that's my point. Is that in terms of seeing a patient in the field, this information does not help you determine exactly what's going on with that patient. It tells you, well, there's something significant, okay? Patient's not as responsive. Why is he not as responsive? Is it from a stroke? Is he postictal and having a Todd's paralysis? And I'll going to give you that information in a minute. I think that was a case that I gave last time, but Jesse said I didn't give it to you guys. I may have forgotten to give it to you. Is the patient septic? Is it a metabolic process? Here's an example. 48-year-old female. EMS calls stroke alert. Left hemiparesis. No speech issues. Brought her from hospice. What do you think? I'm sorry, I forgot to add that she's awake, alert, and oriented. Okay, blood sugar was 100. Think about that for a minute. Left hemiparesis, Jesse. No facial involvement. From a what? Possible. She's 48. Ah. That's the whole crux of the issue. She's got metastatic cancer. She's in hospice. Basically, she refused any further intervention. She drinks every day, a very pleasant woman. A friend that was with her was castigating her for drinking, and I said to the friend, I said, really? I said, you're giving her a hard time about drinking? I said to the patient, do you like to drink? She goes, yeah, makes me feel better. She's a very pleasant woman. I said, turn to the woman who was standing at the foot of the stretcher, and I said, she likes to drink. What's she have to lose? That's the same mindset of a patient who has cancer that's all over the place, being afraid to give them medication for pain because you might make them an addict. So, stroke alert. They never asked the question, why were you in hospice?
Really?
They never asked the question. What do you think she had on CAT scan of her head? 3 big tumors in her brain. I said to her, what would you like me to do for you? She said, well, she said, just, yeah. She said, I just want the pain controlled. She said, I said, no problem. I gave her some Decadron, which is a steroid. I said, I think you should come in since this is the first time you've had this, so we can get an idea of how extensive this is, make sure you didn't infarct your cord or something weird like that. I said, this to me appears to be all related to the tumors in your head. She said, okay, that's fine with me. Medicated her, admitted her. She went home a few days later on Decadron to try to help keep the tumors shrunk a little bit. Perfectly happy, knowing that this was the end. It would be quicker than she anticipated. But so, again, if you didn't know her history, you would have thought this indeed was a stroke from the usual thrombotic event or hemorrhagic event. Okay. However, remember what I said, she had no facial involvement at all. And when I asked her some very specific questions. 1, any vision loss in the last few weeks? And at first she said no, and then she said, you know what, wait a minute. She said, yeah, she said, I notice that when I look a certain way, I can't see whatever it is I'm looking at. Ah, so she has a visual field cut. That's significant. I said, have you been having any headaches that seem to be different to you than what you've ever had in the past? And again, first she said no, and then she said, you know, I've been getting a headache back here. She had 1 big tumor in her occiput, 2 others in her parietal area on the, I think it was the left side of her head. Now, was I a Svengali knowing that she was going to have tumor in her head? No, those are normal questions. This woman had no speech problem. She wasn't dysarthric, she wasn't drooling, nothing. So that would be a normal question with the first question that I asked her, why are you in hospice? Which is what the medic should have asked, but they didn't. They didn't ask, they came in, stroke alert. Well, okay, where'd you get her? Hospice. Right then, you know, they got her from hospice. The stroke alert more than likely is related to a tumor in her head. And they didn't ask any other questions about it. Yeah. I mean, and she wasn't obese. She was a thin woman.
So they didn't ask anybody at hospice that was in charge of her care what her history was?
Didn't even ask her, and she was perfectly lucid. Well, this is why I always tell you that this is important stuff. If history and physical will make your diagnosis for you. It will. The patient, I had an old professor in school who used to tell me this all the time in medical school and in internship. He said, the patient will always tell you the diagnosis. You just have to make sure you ask the right questions. And it's true. They'll always tell you the diagnosis. I mean, they're not going to say to you, oh, I have 3 tumors in my brain. They're going to tell you, yeah, you know what? I have had some vision loss for the last couple of weeks. Yeah, I've had this nagging headache, but I didn't think much of it because, you know, I used to get headaches occasionally, but yeah, most of the time. Unless her nagging friend is there yelling at her about drinking.
With this patient, if you were to take the hospice part out of it, but she still had the left side paralysis, it's still not really enough to call stroke.
Well,
Or would you back?
It is on the new protocol.
yeah, see, the difference is that, and this is leading into the changes. Yeah, in the new protocol it is. Okay. You,
One thing and a blood sugar over 60.
right. And what's important is it's better to call it than not to, because there's that window. And this is a problem I've seen happen all the time, is that you get a patient in, they call a stroke alert, you get them there, and what's the worst that can happen? They're out of the window. That's the worst that can happen.
What is it now
Well,
Analytics work in what matter of time?
see, the data is changing. Initially, 3 hours was the window we had to give them TPA. However, they've done studies, and I don't have offhand where they were published, but there's been probably now 3 or 4, and one was in the New England Journal of Medicine sometime in the last year, not 14, but 13. And they looked at doing this as much as 5 hours out from the time of onset, and it still had good results.
Because we went 3, then we went to 6, now we're at 12. I mean, they either advance the thrombolytics.
It's going to probably eventually, before thrombolysis and specific arterial thrombolysis, before any of that was ever done, the rule of thumb was that you had a deficit. You couldn't predict if that was going to be a stroke or not for 24 hours. It took 24 hours for that thing to firm up and make a decision. It would either resolve or it would be permanent at that point. So if you take that information that they used for 60 years and apply it with what they're developing now, and as they continue to do this and get more knowledge and experience with this, I bet you at some point you're going to see 24 hours.
That was my question, because I know thrombolytics is fairly recent, in the last 12 years,
Yeah. The only difference is that now, they have these interventionalists that can actually go into the site and do what has to be done, which is different. I mean, that's only been recent, and there's only one guy in this area that does that, or, well, 2 guys, and they're down in Naples. So that's been a change. But the data that they used originally came from cardiac. It came from using the TPA in cardiac cases. And that's what they used for their original data, and that's what they used as the original time frame. So as time goes on, you may see that change. The only thing is, though, is that what's a big problem with thrombolytics, or actually any kind of anticoagulant, not just anything, in a stroke patient, you can convert an embolic stroke to what? Hemorrhagic. That's the problem you run into. So you have to be careful. That's why they move slowly with this. An embolic stroke, a little easier to take care of. You have a hemorrhagic stroke, those patients usually don't survive. Most of the time they're deep in the circle of Willis. And you can't get into that area unless you have an interventionalist that can go right into that area and put a coil in or something to stop the hemorrhage. Otherwise, you're going to die, because there's no way to operate that deep going through the nose or drilling a hole in the head, because you're going to damage brain tissue going in to stop that, because the circle of Willis is at the base of your brain with all the vessels coming up into the midbrain. Okay, another case. Same thing, 43-year-old, obese patient, left hemiparesis. Get a call from EMS. We got a stroke alert coming in. Okay. Now, what does that mean? Well, that means they go right to CAT scan and then come back to the ER. They stop at the desk, I look at them, they go to CAT scan. They pull in with this woman. I'm looking at her thinking, shit, I know this lady. I know her, she's been here. What has she been here for? I'm trying to think about it. Go over and talk to her, and she says, oh, I can't move my left side. Perfect speech. No facial involvement whatsoever. When did this start? It started after dinner on my way home. Ever have it before? Yeah. I said, did you have a stroke before? I don't know. I said, well, you've had this before, so did you have a stroke? Did they tell you it was a stroke? No. Now I know who this woman is. She goes over for CT, comes back, the radiologist calls me and he says, I don't see anything. I said, yeah, and you won't either. I said, this lady has, she says it started after a seizure. That's when I realized who she was. Witnessed pseudo seizures on video in a hospital, telling the doctor while she was having the seizure, I'm having a seizure. Yeah, my arm and leg are shaking. So she carries a diagnosis of pseudo seizures. In addition, very strong psych history, Munchausen syndrome. What's Munchausen's? When you make yourself sick, or you make your kids sick, or you make your husband sick, so that you can get the attention and pretend you're the rescuer. I'm saving them. I'm helping. I'm taking care of them, but you're making them sick because you're poisoning them or whatever you're doing. Very strong psych history. So I realized that's who she is. I pull up her records, because initially I thought maybe she had a Todd's paralysis when she told me she had a seizure history. Todd's paralysis will look like a stroke, happens after a seizure. They can be postictal, where they're somewhat obtunded a little bit but still reactive, or they can be awake and not be able to move aside. It goes away in a short period of time. I think the longest I've seen one is almost 24 hours. So I thought initially it was a Todd's paralysis until I pulled her records. And I knew she had some psych issues. I didn't know she had Munchausen's until I pulled her records and looked at them and saw that her last 10 admissions to the hospital, 10 mind you, and I'd sent her home previously for pseudo seizures, but her last 10 were for the exact same thing. She wasn't on seizure meds. She was on a ton of psych meds. She would present the same way with a hemiparesis, alleged hemiparesis, saying she can't move. She comes back from CT. Now she says she can't move her right leg either. Do you know of any stroke that gives you both legs and one arm involvement?
The global one.
So, but you understand the difficulty in dealing with these people. And if you saw her, there'd be somebody you would be seeing all the time. And at some point, yes, these people can actually get sick, and that's the problem, is that you can get burned because they can actually have a problem. But it's important to know the significance. I still would have recommended you call the stroke alert, because it's always easier to undo that than it is to bring a patient in and then the doctor says, shit, this should have been a stroke alert. Now, we call them in the ER too. I've done that at times. And what I didn't realize, well, I should have realized, but I didn't, was that when you do that, the hospital gets a higher level of reimbursement. Like a sepsis alert. They say, oh, we're going to call a sepsis alert. And I said, why? The patient's not tachycardic, not hypotensive, doesn't have a fever, probably got a urinary tract infection and maybe a little bit of septicemia, but she's not critical. And in a sepsis alert, they require a central line and ICU admission. And lots of fluids. So I finally get to the bottom of what it means. Oh, well, if we call that, we get paid more. Okay. Same thing with a stroke alert. So the STEMI alerts, which probably were one of our original ones years ago, that's how this originated with all these alerts. That's how these hospitals get paid more for these Medicare patients that have these alleged problems. So in terms of what you do in the field, just call it. And you can do the same thing with sepsis. Do they do sepsis alerts in these hospitals down here? No. Okay. Okay. Sorry for the little detour we took, but it has to do with what we're talking about. Anyway, what were we talking about? Okay, some neurologic issues. We know the neurosystem's comprised of the brain and spinal cord. You have your basic functions located there. Your CNS, thought, perception, autonomic body functions, peripheral nervous system, all the things off the spinal cord as well. And Jesse, wasn't this your lecture for next month?
Yes, you're doing a fine job at it.
Okay, good. Just an example of what does what. I mean, I can't even read some of this.
That's okay, you can skip over it.
But it just gives you a breakdown of the central and peripheral nervous system. You'll find this in any paramedic book. Talk about the brain. Now, remember what I said, and that lady with the cancer, what did I tell you she was having? Visual problems, okay, and a headache. Now, what was a visual problem coming from? It was a tumor in the occipital lobe. Remember, that's a lobe that controls your vision. So if somebody says to you, I've been having a headache and I can't see everything to the right. So in this eye, I can't see stuff in the right over here unless it's with this eye, and with this eye, I can't see stuff to the right. Okay? Or they may say to you, yeah, I lost my vision. I had this severe headache and I lost my vision. Still have a headache, but it's not as severe, and some of my vision's coming back. Now, migraines will give you visual field cuts and vision loss, so you need to know that. But
Because I've known people that have had migraines, and with the light disturbances, they actually have like spots where they can't see.
yeah, and that's, I used to have those kinds of migraines for years. I would lose my vision in a particular quadrant, and I knew, okay, now my headache's going to come, because I would lose the vision first and the headache would start. So not every headache is going to be from a brain tumor or increased intracranial pressure. There can be other things that do it. However, what I want you to think about is vision loss that's not locally confined to an eye, that's related to the brain. Usually you're going to have some kind of CNS complaint from the patient. Headache most common, maybe vomiting. I talk about the temporal lobe, okay, your speech, frontal lobe. Now, the frontal lobe is important because patients with personality issues with who are violent and so on and so forth, a lot of that comes from the frontal lobe. Yeah, a lot of that comes from the frontal lobe. Patients with frontal lobe injury sometimes are very docile or very irritable, you know, from auto accidents or whatever, from the bruising and damage that occurred. In the old days, pre-1965, and actually through most of the 30s and 40s, they would do a procedure where they would go up the nose and scramble the frontal lobe for patients that were difficult to control in the mental institutions, and would make them very docile. As a matter of fact, the main reason that all those places were shut down were the Kennedys. Kennedy's father, Joe Kennedy, had a daughter that was born with some mental retardation, and when she was about 18 or 19, she was in an institution, and he had her lobotomized and completely changed her to where she basically was just, non-interactive. And Joe Kennedy's wife, whatever her name was, Rose, was so pissed at him for doing it without her consent, without Rose's consent, that she made it a crusade of hers to eliminate these institutions. They had the money and the power to do it. So what happened was, over the course of time, laws were passed that eliminated the ability to put patients in institutions like this for permanent care, and you don't find them anymore. There's a few, but there's not many. Most of them are going to group homes, which are even worse, because they get minimal care. But that was the impetus to get rid of these places. I mean, there was abuse in them too. You know, there were stories of it being used punitively for people who were not in line with the government or the politicians of that section or that era. So they would commit them to a nut house, and there they would get locked up for years. No, you know who was sent there? Frances Farmer, I think her name was. She was an actress in the 50s in Hollywood. I think it was her. And very, very beautiful woman. She was sent there because she was working on a movie, and I don't know what happened. There was some issue that she wasn't being, to whatever the producers wanted. So they made up a story that she had some mental issues. They put her in this institution. She was there for years. And she was in the institution, the people that ran it were using her as a prostitute. They would sell her to whoever came in and wanted to pay for her. They would keep the money. She would tell the doctors that this was going on, and the orderlies would say, she's out of her mind. She needs more drugs. And in those days, it was Thorazine. So she was just, you know. And that's what they did to her for years. She eventually got out, was permanently, of course, damaged by that time mentally, because I think they did do a lobotomy on her. And that story didn't come out for decades, and it was just sad. And I mean, so yes, there is abuse, no question about it. Parietal lobes, you know, those are your big segments of your brain up here. Talks a little bit about efferent and afferent nerves, and this is what we all have seen the brain, pictures of the brain and what it looks like. So, okay, I want to talk about the pons for a minute, because sometimes, probably 65% of the time, you can tell if a patient's having a stroke if it's located in the pons by the way their pupils look. The old adage for a pontine infarction, it can also be a bleed, but mostly infarction, is your pupils get very tiny and tight. They look like a narcotic overdose. But the difference is the patient's not obtunded from narcotics. Most of the time they're able to talk to you, but the pupils are really small and tight. What else does that? What else does that? Metabolically. Think about it. Metabolic acidosis gives you small, tight pupils. Yeah. Something to think about when you see patients like this.
So the gut temperature is really high and that pimple pupils. Compare that to either the stroke or overdose.
See?
Man's vital sign.
Little star.
Well, that's not-
See, you don't need a CAT scan to know. I mean, you're in a unique position to see these patients, all patients, first, and to be able to formulate based upon your clinical skills, which most of the time exceeds what's being done in the hospitals, especially in the emergency room, because they rely on tests for everybody. But your clinical skills can tell you what's going on with these patients if you pay attention and you look for the things that you know should be there and you ask the right questions, okay? You have to put this together. It's like being a detective. That's what medicine is. It's like being a detective. You know, this is boring as hell. I looked at this and I really debated whether to talk about it. Okay. Who cares? Yeah, that's what I'm going to do. Let's see. We don't want to talk about that either.
There you go. Keep pushing that button.
Where you have an appointment at 11, Jeff?
Absolutely not.
Yeah, right. No, I can't. I have office hours today. I got to go. But thanks for the offer. You all know that. Okay. So
Resilient.
let's look at about what it is that you are actually able to do in terms of patient assessment. So we know from most recent data that you have to be careful with ventilation of the brain, okay? That the old data suggested you had to hyperventilate patients to maintain their oxygenation. The new one says, well, we think that may cause vasoconstriction. We don't recommend it because you'll actually worsen the patient's brain processes and therefore worsen their outcome down the road at 30 days. So let's look at this. This is supposed to be a pulse ox. Okay. Where should the pulse ox be in? All right. You have a patient that has COPD. What do you want to correct them to with your oxygen? Where do you want to put them? Let's say their pulse ox is 88 and they're in distress.